Sean was talking about what I know as health suite labs, C-suite labs, but also recently there was also one of the labs together with the Ministry of Health and the NPCF, which is the patient union. Could you tell us a bit more on that?
Well, I think the essence of Sean's story is that co-creation means that we have to look at all perspectives, and most systems are designed from one or two perspectives, maybe from the leadership perspective or the nurse's perspective or the cardiologist's perspective. Now we say we bring everybody together with the patient at the center, which is of course a familiar theme for you, Lucien. The patient at the center, but how can we optimize around that? And how can we look at everybody's perspective? And co-creation is the process in which you look at each other's perspectives and follow a set of common goals, always about the outcomes of the patients, better quality of care, more efficient care. So you can do that with a hospital system, like we've done together many times, or you can raise it one level. Because if you look at a patient and you look at the reality of care, it's not just the hospital, it's the general practitioner, it's the pharmacy, it's the insurance, it's the physiotherapist, it might be a psychiatrist with a private practice. And it's also the environment of the patient, because we look at the true drivers of health, and many of them are not clinical. It's your social environment, your health education, it's the stimulation you get around you, it's how you behave, what you eat, how you drink, how you exercise, how you sleep, and all of these are relevant. So now we're taking it one level up and say, okay, now let's look at the broader environment. Let's look at what a ministry should stimulate to get better outcomes for the overall population.
So that's more like population health management.
Yeah, but always bringing it down to what it means for an individual.
Yeah, sure.
And then you see that these ecosystems are actually quite complex. You have home care organizations, you have hospitals, you have clinics, you have general practitioners, and rarely do they work together, They work alongside.
I like to call them out like ecosystems, as you know.
I think they're ecosystems, and I love your saying there, and they have to become ecosystem, because an ecosystem means roles and responsibilities are clear. There's a set of common goals, and you understand by working better together, you can create better outcomes. So we did a Health Suite Labs, which was actually at the initiative of our Ministry of Health. And we had 27 organizations represented there, and you say, okay, that's a recipe for chaos. Especially in the Netherlands. In the Netherlands, everybody loves to have an opinion about stuff. But at the other hand, you have the consensus culture, so how the hell do you get 27 people to 27 organizations?
Even without the politics.
Yeah, but it was highly effective. Why? Because of what Sean just said. We were all inspired by the fact that we can make life better for 17 million, Dutch citizens. And we all recognize that better collaboration, more clarity, better focus on outcomes will move the needle. And we understand there's nobody that can do it alone. Radboud is great, and Radboud is a front runner, and Philips is a great technology company, but the world is way bigger. And if we can bring people along and share a vision, share the excitement and understand that we can move the needle, I think that brings people along. And that's the entire purpose of the lab. And the lab is really about co-designing and proving that you can move the needle quickly if you truly work together.
Let's elaborate a bit on nationwide approaches and global approaches. Because one of the things we share dearly is that we don't think that the Netherlands alone can pull this off. The same would be for Belgium. And healthcare is globalizing. What's your specific approach as Philips, also from the standpoint of view, like Sean shared with us, also about the Health Suite digital platform?
Yeah. So what we believe is that you need a health infrastructure. If you look at the financial service, there is a payment infrastructure that allows us to pay anywhere, to go to an ATM and withdraw cash anywhere. So we need something similar. We need a health infrastructure that allows us to follow the patient and help them accumulate information about them. That will help them with their own personal pathways through the system. But more importantly, that also tees up the information that we can use for research, for innovation. Because if you buy into the notion that what drives health is actually complex and requires a whole lot of data and perspectives, then you will buy into the notion that if you can bring that information together, if you can analyze that data, you will find the real drivers of health, which in turn can be brought back into the system and allow you as a patient to make the right decisions. You know, maybe help you to take your medication on time. But more importantly, it can help a care team to intervene at the right moment, or it can help a clinician to do a better diagnostic, because they don't just look at a sliver of, you know, they don't just look at your heart, but they understand the person in which the heart is beating, but they also understand the context of that person, and therefore they can make a better diagnostic, but they can also do a better treatment plan that fits with your needs, your risk approach, and your capabilities to self-manage.
Which is more the holistic approach.
It's a much more holistic approach. And if we can work together on that common infrastructure, I think it not only creates better care, it also prompts a whole new wave of innovation, and it has to transcend borders. Because, you know, today you can travel to around the world, you know, just like you've done.
Within 24 hours globally.
You can travel around, but you can also pay around the world. Now, we want to do the same with health. You should be able to accumulate, you should be able to get the right information wherever you are and get the best treatment you need.
Yeah. So one of the other things that we see often is that there's a clearly discrimination still between cure and care.
Yeah.
Could you share a bit of your vision on that, how we could actually get those barriers or those walls and tear them down from, for instance, a digital perspective?
Yeah, again, if your starting point is looking at the real drivers of health, then clearly care is part of the cure. You know,
sure.
What I mean is, the better I can support you in self-management, the better I can help you avoid deterioration, the better I can help you live more healthy, the better I understand what your true root cause of your illness is, the better I can treat that illness. So care and cure are two parts of the same coin, and they heavily influence it.
It's a marriage indeed.
Yeah.
So I think this is a good moment to invite our Secretary of State, Martin van Rijn, from the Department of Health, to join us at the table, and we're very proud to have him over here as well. Mr. van Rijn. Welcome. Have a seat. Jeroen and I were just talking and sharing a bit about population health management, about the clear discrimination still between cure and care at the other side, and also a bit about the Health Suite Labs that recently, on the initiative from the Department of Health, was done together with 24 organizations at one stake. What we're looking for today is the perspective from the Minister of Health. How could you change this from a governmental standpoint of view, using technology and using also companies together with patients for it?
Well, I think technology could be of huge help in, let's say, tackling the problem of an aging population. Probably you already talked about integrated care. Look at a disease like dementia, in which it starts with there's not a very good feeling at home, but you don't know what it is. And it ends up with probably your way to a nursing home. And in between, you get all kinds of care. Sometimes you go to the hospital, sometimes you get a home nurse, sometimes you get to see a doctor. So, well, at least from a standpoint of exchange of information, you need to have a very integrated approach. So that's information technology on the smallest level. But staying at home as long as possible, having signals about how your condition is. If you want to enable people to stay at home as long as possible, if they want, then I think the use of technology is inevitable.
Yeah, absolutely. So Frans van Houten would love to join us originally, but obviously there's a huge IPO going on from Philips Lighting at this moment. So I would like to invite you to have a peek at a view of a video from Frans with a statement about the circular economy, which is also one of the dear subjects for us.
The business model was, I make the product, I sell it to you, you use it and you discard it. In a circular economy thinking, we take a different notion. We actually will recuperate the value of the product when it comes to the end of its life cycle. We can either repurpose or refurbish the product for another use cycle, or we can recuperate the raw materials from the end product and recycle them so that we can build another product. In circular economy business models, I would like products to come back to me as the original designer and manufacturer. And once you get your head around that notion, why would I actually sell you the product if you are primarily interested in the benefit of the product? And maybe I can stay the owner of the product and just sell you the benefit as a service. If you carefully look around us and we look at other companies, there are plenty of examples where circular economy thinking is applied. Aircraft engines are often made by Rolls-Royce. Rolls-Royce has a business model where they stay the owner of the engine and make sure that they sell aircraft flying hours. I would love this to become further ingrained, and not only for B2B business models, but also for B2C business models. In the circular economy thinking, people in the company have to start thinking differently. That applies to marketing, product design, but also to management, especially to management. Because how do you measure profitability in a circular model? The initial cost price of a product that is circular can actually be a little bit more expensive because it's designed to take the modules back and to recoup the value at the end of its first life. That means that you need to measure profitability maybe over an 8 or even 15-year time frame. And if the product is 5% more expensive initially, but I get 30% of the value back after 8 years, then that's a great proposition, right? But it does require us to have a long cycle in judging the value of a customer relationship and a business model. I often get questions whether circular economy thinking is understood by shareholders. And I dare say, if we do a good job, yes, shareholders understand it and even can appreciate it. And why is that? Well, shareholders actually like to have predictable results. And if I build up my business with recurring revenues that come out of a base of customers that will take my product as a service rather than only, the hit and run of the linear model, I can build a very profitable and recurring revenue stream. And shareholders like that. So initially, the reaction may be, let's focus on the quarter, let's focus on the next half year. But long-term investors, value investors, are interested in understanding how the company builds up a recurring revenue stream, which fits perfectly well with the circular economy thinking. Philips is the leader in energy-efficient lighting, but energy-efficient lighting is a little bit more expensive, and maybe up to 30–40% more expensive than traditional lighting. And that puts customers off. We went to Schiphol with a proposition where they can buy lighting as a service. That takes away the initial adoption barrier. It saves the Schiphol airport 50% of their electricity bill. It gets them a product that lasts up to 75% longer, so they have less replacement cycles and they save labor. And it gives us a relationship with Schiphol Airport that will last many years. It actually reduces my selling expenses, and it continues that ongoing business partnership. All in all, this deal was very profitable, both for Schiphol Airport as well as for Philips. In healthcare, we design and make medical scanners, often, $500,000 to $1 million a piece. And there's a lot of very valuable parts in a scanner like that. Nowadays, we design so that we can recoup later on from our customers these machines. We take them all back, and then in our refurb factory, we repurpose them and we make them almost as new, and we can sell them to other customers. From a design perspective, we had to design the product so that it would be easy to take it apart, that certain modules would indeed, as the word says, be modular, and they can be reused in the second life of the scanner. My recommendation for those of you who are considering to embrace the circular economy thinking in your business is to assemble a few people, marketing, R&D, manufacture, sales, and have a workshop where we clear the plate, we open the mind, and say, you know, what is it that we really offer to our customers? I think you will be surprised on how inspiring that session is going to be. How much energy will be unlocked through that, you know, brainstorm. And I would also advise you to involve your customers. What are they really after from you? What do they value in you? Is it the product or is it the benefit of the product? It took Philips 15 years to get where we are. So don't think that, you know, this is a solution overnight. You will grow into it, I'm sure.
Jeroen, this clearly is affecting your business groups and also the way you work. I got two questions for you. How long would it take you that we as Radboud University Medical Center can no longer buy stuff from you and turn into buying services? And secondly, what can the government do, or what do you need from the government to create within the policies of them?
Good questions. Let's start with the first one. And I want to come back to what you said earlier about, you know, we need to support elderly people at home because they have deteriorating cognitive abilities. Most of them have one or more chronic diseases, yet we still want them to live a purposeful life. So we have a product which is actually a service. So it's called Lifeline. It's a little device that hangs around your neck, and it has a big button, and if you need help you can press it, but it also has fall detection. So if a healthy person falls down, it can trigger a response and intervention. But that's the base service, and we don't sell it as a product, so you don't own the product, you use it. But then we wrap services around it. So we've been working with you, for instance, with ParkinsonNet, because we all know that people who suffer from Parkinson have a very high risk of falling. So we started looking at, can we provide that as a service? So do we actually, can we help people, but more importantly, can we start predicting that somebody's going to fall? So we have developed the algorithms where we see when people get up more slowly, their gait is changing, suddenly we can see the risk of falling increasing, and therefore we can intervene. Now, how can we intervene? We can send somebody there, but we can wrap around it in a technology service. So we launched a service where people actually play games, you know, on their television, and they're asked to dance and move, which gives us a good sense of are they improving, but we can also stimulate them for other parts of their brain to become more active. Now, what we've been looking at with you is, can we also use that information to get a much better sense of whether a patient is deteriorating, what would drive that? So can we understand the contextual information, which, and again, helps us to be able to intervene at the right moment, you know, so we can help people live at home. But for Bas Bloem in Radboud, this is extremely valuable research information, which can help him have a much better understanding of how the disease evolves and what we can do to intervene. Now again, if you combine that, for instance, what we're doing in medical imaging, you can also start looking at what's the actual situation in the brain of the patient. You know, is the plaque increasing? If we apply some medication, will it actually stop forming the plaque? So there's a whole world of science. And again, if we start providing these services, for me, the next generation of services we're going to provide is sitting down with yourself, with Bas, and saying, what are the outcomes we're striving for? Can we really help Parkinson patients to better control their condition? Can we actually stop it in its track? And you pay us for these outcomes.
Which is also the question for instance, the government in shifting from pay for services into outcome finance.
Exactly. So I was teeing up the answer to the second question, because I think, yes, the government can help us, because ultimately it is about outcomes. It is not about doing that MRI for that Parkinson patient. It is, how does this MRI contribute to a better state of the patients? And ultimately, I think if we organize around those outcomes, we'll change the way we provide care. We will stimulate people actually to work together in an integrated way, because we're all marching towards that same goal, you know, better outcomes for the patients.
Is that a challenge for the government?
Well, I think, let me say at first hand that politicians know a lot about circular economy because they are circular products themselves.
Yeah.
So
Highly
something's
circular.
coming up next year.
Yeah, something. When you look at the financing of healthcare, we now generally pay for 1 hour service from a doctor or for a nurse. So we finance input. So it's very important to have the financing of outcome, which is very difficult because you have to be very clear at the beginning what kind of outcome you expect and what you will be financing. Maybe there's also another way, and that's simply to have less rules and regulations. Just make decisions about the budget and say to the hospital, well, within this budget, you can do your thing and optimize it.
Yeah.
So I think the 2 ways to go is indeed output financing, but you have to define what the output is, which is in practice in healthcare still very difficult. Or giving more room to move from doctors or hospitals themselves by giving them a long-term budget and say, well, optimize it yourself.
Yeah. But I want to come back to these outcomes because some of the outcomes are relatively simple to measure. So if you say we provide this kind of care, can we avoid, you know, a patient having more need for emergency care? Because that's the highest cost in the healthcare system is emergency care. Can we avoid rehospitalizations because we intervene earlier? So just do very simple metrics, you know, less to the hospital, less emergency care. First 2 important metrics that are directly related to quality because people don't like to be in hospitals, you know, despite we can make them great and beautiful. You just seen that in the video, or we can have a great team at Radboud. Still people prefer to stay at home.
Yeah.
So then of course you have a third quality metric is, you know, allows it me as a person to function a normal life. Can I go back to work? Or if I'm not at work, can I at least, you know, have a normal life? And I think we can make it extremely complicated, or we can say, you know, let's simplify it. Let's drive to some of the more important outcomes. And then, you know, we can get more refined as we get along.
I very much agree with it. But I don't think, maybe defining the output isn't the hardest thing.
No.
You proved it already. The hardest thing, I think, there are very much different parties involved because when you save from going to a retirement home, maybe you have to give a little bit more money to the nurse or to the hospital, and you can save money in the retirement home. But there are different systems and different people, and different people own their money, earn their money. So that's why it's maybe not a health, not a health issue or defining the output, but a process issue. What people are in favor of it or who are against it, who has profit and who don't have the profit.
Yeah. Indeed, since the patient is not a divided product, just for the sake of the word for now, we kind of divided all the financial systems in those silos, and that's where we have to de-silo these kind of things, which is, by the way, also one of the things that comes in the digitization of healthcare and data transparency. That will have a huge impact on that.
Yeah.
And if you would like to prep your talk already, I have one question for Mr. Van Rijn in this perspective, is what is your biggest challenge for the next 2-3 years in these kind of perspectives? And then Jeroen can walk up already to us.
Okay.
I think my greatest concern is how to speed up the process, because everyone in my speech I will elaborate on that, but there are so much possibilities, there are so much inventions, there are so much really simple e-healthcare apps or other appliances you can use today. But the process of getting them in healthcare in total, it takes us maybe 10 or 15 years. So my greatest concern, we don't have that time anymore. We need e-health now. So speeding up the process, scaling up the process, trying to find new finance systems, I think that's my greatest concern. It's concern. It's concern. It's concern. It's concern. It's concern. It's concern.